Welcome to the PCEP of May 2020, which should be the second COVID-19 PCEP. We're going to talk today about management of stroke. We're trying to get back to somewhat on track. I know we've been all spending most of our time dealing with the COVID issues, but still the rest of our life goes on, and we have just as many cardiac events, sepsis events, stroke events, as we always do, just on top of the COVID issue. So we have to be careful about our personal protection. So let's see if I'm not getting control of moving my slides around. Okay, so we have a few housekeeping things to do today that do have to do with COVID, and then we'll talk about strokes, epidemiology, management, and protocol. We have some legacy and some Peace Health stroke data as well. Housekeeping event first. I want to talk a little bit about the patient transport and non-transport. We've been having a lot of patients who have been opting out of, they've been calling 911, having an evaluation by EMS, and then opting to not go to the emergency department for fear of being exposed to COVID, which is, of course, not a realistic thing now. Now that everybody is covered head to toe in PPE, and probably it's the safest time ever to go to the emergency department as far as exposure to the staff. We have had a number of patients who've had significant cardiac and stroke issues and have opted to not go. We had last month, I had informed you of the criteria which we would use in extreme condition of overwhelming emergency and overwhelming use of EMS and of the emergency departments, and overwhelming of the system in evaluating patients who we would think who might even have COVID, but who would be safe to leave at home. The nice thing about this exercise was that it also gave us the option of being able to emphasize which patients you should not leave at home, and if they opt to be left at home, that you would contact medical control and attempt to have medical control physician or their own personal physician discuss with them the options and to try to encourage them to go to the hospital. This is not an EMS refusal of service protocol. By that we mean this is not for you to say, I'm sorry, sir, we are not going to transport you because you do not fit the criteria. So the patients, if they have a chief complaint requiring treatment and transport, they should be transported, or they should be in contact with medical control physician or their own PCP in the case of patients in the nursing home. The criteria which we would use to say this person should or must go to the hospital is patients who are older than 60 and ill or have symptoms, patients who are less than 18. Not so much because children have are at particular risk for COVID or for anything, but they are considered more highly vulnerable for other issues, and also because under the age of 18, they can't give their own consent. Their vital signs are should be between 10 and 20. If they're outside of those, the respiratory rate is outside that level, then they should be transported or encouraged to be transferred. If their heart rate is greater than 100, they also need to be evaluated. The systolic blood pressure is less than 110, they need to be evaluated. And SaO2 should be equal to 94 or better. So they must, if they do not have the ability to ambulate, and if they have no decision-making capability on their own, if you judge that their decision-making capability is and capacity is poor, then they also should be transported. They cannot have had syncope, altered mental status. If they have a history of diabetes, congestive heart failure, COPD, asthma, immunocompromised, or currently pregnant, they need to be transported or discussed with medical control. If you feel that the patient would be unsafe at home, same thing applies. They need to be transported, or if they opt for AMA, that they need to have discussion with medical control. All right. I hope that that will help clear up something. We've had a few refusals lately that I was a little bit concerned about because they happen to be probably cardiac and or stroke in nature and needed consult. So we are reviewing all refusals, and we'll be contacting you if we think there's an issue. Okay, on to the subject of the day, stroke. In the United States, we have about 140,000 deaths per year from stroke, 1 out of every 20 deaths essentially. And this is almost out of almost 800,000 strokes. So that puts you into the 20 to 25% fatality rate from stroke itself, the first stroke. So about 600,000 or so of these strokes are first or new strokes. Almost 90%, 87% of all strokes are ischemic in nature. Stroke is the leading cause of serious long-term disability and also of long-term expense. Ischemic strokes come in, which are occlusive in nature, so the vessel is occluded, comes as a thrombosis, either de novo at the site of the directly at an artery, or as an embolism. So an embolism generally comes from the mitral valve small clots, thrombi that build up on this, particularly in cases of things like atrial fibrillation, which is why we have you do a monitor or at least a 12 lead on the patient to rule that out as the source. Also, emboli can arrive de novo in carotid arteries, for example, and then break loose a small clot and embolize to the cerebral circulation. Most of the majority of our strokes are anterior circulation strokes, occlusion of the carotid artery distributions, and the rest are posterior circulation strokes, vertebrobasilar artery, which involves the brainstem or cerebellum These are strokes that we're particularly interested in nowadays because there's a high miss rate in diagnosing these. Hemorrhagic strokes are generally from aneurysms. Subarachnoid bleeds are generally from aneurysms, although occasionally a person will have an arteriovenous malformation, which is a congenital defect, and these generally show up in young age groups. Intracerebral hemorrhages occur from hypertension most commonly, and from what's called amyloid angiopathy in elderly persons, where you have buildup of amyloid material in the small arteries, causing occlusion or rupture. Now, there are some modifiable risk factors that, so things that you can do, you can make improvements in. You can control hypertension, stop smoking. Smoking is highly associated with strokes and any other vascular issue. If you have a history of TIAs, this is nature's way of telling you you're going to have a stroke. And so you need to have that evaluated, and if it can be fixed, fix it. Heart disease, including atrial fibrillation, diabetes mellitus, of course, diabetes, hypertension, renal disease all go together. Hypercoagulopathy, patients who are pregnant, patients have a higher risk of stroke during the pregnancy due to the clotting, the coagulation issues associated with hormones of pregnancy. Patients with cancer have a higher risk of stroke due to coagulopathies. Sickle cell disease, an increased red blood cell count patients with who have polycythemia, either polycythemia vera, which is a genetically determined condition, or polycythemia from severe COPD, have an increased risk of stroke. History of carotid bruit. Bruit is a noise. It's like a heart murmur, only you hear it over the artery so the carotid artery in the neck, and this can indicate a narrowing of the artery, causing the bruit, which is indicative of arteriosclerosis of the carotid, and a clot can build at that point, or you can get total occlusion. This is something that can be treated by surgery. Unmodifiable things, risk factors: the older you are, the more likely you have a stroke. You can't change that. Gender, well, you can't really change the gender either, but as far as your genetic makeup, as far as the things that contribute to genetically to the stroke. Race is not changeable. Higher incidence of stroke in African Americans and persons of color in the United States, possibly due simply to some racial factors, but also possibly due to socioeconomic. Previous CVA, if you've had one, you're more likely to have another. And then heredity. The best thing you can do to not have a heart attack, or to have, as a young person, or to have a stroke, is to pick your parents, and it's even better if you can pick your grandparents. All right, signs and symptoms of ischemic stroke in the carotid circulation. Unilateral paralysis, usually opposite side of the cerebral hemisphere that has suffered the stroke. Numbness on the opposite side. Language disturbance, aphasia, difficulty in comprehension, nonsense words, difficulty reading, writing. That's why we ask persons to repeat a phrase. Dysarthria is slurred speech, abnormal pronunciation. Another reason we ask them to repeat a phrase. Visual disturbances on the opposite side. Monocular blindness on the same side. This would be an occlusion of the, basically of the ophthalmic artery. Now, in the vertebrobasilar circulation, the primary symptoms are vertigo, visual disturbances with both eyes simultaneously, diplopia. This is going to be caused by ocular palsy, which one eye is or both eyes are unable to move to one side, or disconjugate gaze, which is asynchronous movement. So either way, the patient will complain of or see double in certain aspects of gaze. So if they're looking straight ahead, they may not see double, but if they try to look to one side or the other, they will generally see double. Now, then there's paralysis occasionally, although it is generally not as severe in the it's not as severe in the vertebrobasilar occlusions as in the anterior middle cerebral. Numbness can happen. Dysarthria, so difficulty speaking again, and ataxia. Ataxia is severe unsteadiness of walking, unsteadiness of moving your hand, arms, inability to control fine movements of your hand or feet. This is a general picture of the circulation of the brain to give an idea of where these things are. This is the internal carotid artery on both sides. See, it's coming up. We're looking at the underside of the brain. So you've got in the internal carotid artery, and then you'll have the anterior communicating artery and the anterior cerebral arteries going that way. Here you'll have the middle cerebral arteries coming off, and you see this is the big stuff. These are the big ones. This is the posterior communicating artery, and this goes all the way around, sort of around the center thing. And this is the lovely so-called circle of Willis. Basilar artery comes up along the spine, the spinal cord. Here's your spinal cord. And you have two vertebral arteries. They join and they become the basilar artery. And the basilar artery comes on and communicates right here with the posterior communicating artery into the circle of Willis. So you can, if you have carotid, if you have weakness or a partial occlusion of the carotid arteries, the basilar artery will feed the anterior cerebral circulation through the circle of Willis connections, as long as it's healthy. Now, the vertebral branches off to all sorts of wonderful little things. The posterior cerebral artery, there's lots of little perforators here. There's little perforators that come into the spinal cord. Sometimes when you have a stroke and these perforators, you end up with what's called the locked-in syndrome, which we will talk about. Now, hemorrhagic stroke, subarachnoid hemorrhage, is characterized by sudden severe headache, would be the most common but it may be very transient. It will also be transient loss of consciousness, nausea and vomiting, because this blood gets often into the cerebral spinal fluid, and this causes quite an irritation, which causes the headache, causes severe neck ache, neck pain, and it also stimulates nausea and vomiting. They're often very intolerant of noise and light and altered mental state. Now, there's a thing called the sentinel bleed, which is the sudden severe headache, and then the patient seems to be okay, although maybe a little bit different than emotionally, etc., than their usual self. They may or may not complain of the neck ache and the severe headache. This is the warning sign that there's going to be another major bleed happening, because the characteristic of subarachnoid hemorrhage, particularly from aneurysms, is that it's related to increase in blood pressure, and then a blowout of the weakness of the artery, which may seal itself transiently for initially as the blood clot, and then rupture again as a more significant and perhaps fatal bleed. Intracerebral hemorrhage is usually some focal symptoms with loss of consciousness, often coma, nausea, and vomiting. You notice that most strokes, most run-of-the-mill strokes from ischemic strokes do not generally cause coma or total loss of consciousness. Whenever I hear somebody who's become comatose or loss of consciousness, and they're significantly impaired, I think intracerebral or subarachnoid hemorrhage. There's a huge differential diagnosis of stroke. It's easy to consider that there's another cause for the symptoms you're seeing, particularly if the symptoms are slightly are not terribly profound. So, head and cervical trauma can cause symptoms just like a stroke. Meningitis and encephalitis, of course, generally speaking, the patient would be septic as well, or they'd appear to be febrile, to be have an illness. Hypertensive encephalopathy, obviously you're going to suspect that if the patient has an extremely elevated blood pressure. Intracranial masses, including tumors and subdural epidural hematomas, can cause stroke-like symptoms. Generally, it'd be associated with a history of some sort of fall or some sort of head injury, which might have been very minor to the patient. Todd's paralysis is a fascinating thing, which is a brief period, although I have had a patient in the past with Todd's paralysis. Todd's paralysis occurs after a seizure, and the patient appears to be in a stroke. Temporary paralysis, usually just on one side of the body, probably indicates that instead of a stroke, that the seizure has disrupted neural pathways in that distribution of the cerebral hemisphere. Generally speaking, Todd's paralysis lasts for perhaps a few hours, although I have had a patient that had a Todd's paralysis for better than 3 or 4 days, and of course that was very dicey to figure out whether the patient really had a stroke or not. because we didn't have quite the same imaging abilities that we do now. Migraines can give stroke-like symptoms, neurologic symptoms. In the absence of a headache, it's called a migraine equivalent. And instead of getting the headache, they get a paralysis or a stroke-like appearance, generally again on one side of the body or the other. But this is related probably to spasm of the arteries premonitory to the migraine. Generally speaking, if the headache occurs, the neuro symptoms go away then. Metabolic, don't forget hyper and hypoglycemia can always give stroke-like symptoms, which is why it is mandatory that we do a glucoscan on any patient who you're considering altered mental status or stroke-like symptoms. Post-arrest ischemia can appear to be stroke. This is why we generally cool patients and we warm them after a day or two to see if they're still having neurologic symptoms. Drug overdoses, of course, can cause all sorts of different neurologic appearing symptoms. There's the old mnemonic AIOU tips, and we won't go through those step by step, but there's a syndrome or a thing for everything. So alcohol, very common in acidosis, epilepsy, encephalopathy, sepsis, treat sepsis just per protocol, but we'll consider that might be a stroke as well. Opiate overdoses, trauma, hypo and hyperglycemia, poisoning, psychosis, stroke, seizure, syncope. Once again, another little picture to remind you where all this is. Here's your internal carotid artery branching out to the big middle cerebral artery. This is where most of your action occurs. Anterior communicating artery. The ophthalmic artery is right here coming off the internal carotid. If you block the ophthalmic artery, the patient is blind in that eye. Posterior communicating artery, so this is all your circle of Willis, and this is your posterior cerebral artery here, basilar artery, anterior inferior cerebral artery, labyrinthine artery going to the ears, the labyrinth, which is why dizziness and vertigo occurs. Posterior inferior cerebellar artery, also called PICA, easier to remember. And the anterior spinal artery. You get a stroke in the anterior spinal artery and you knock out the entire spinal cord. So where do we get strokes? Well, anterior cerebral circulation only accounts for 2% of strokes. Almost not worth paying attention to. Your middle cerebral artery, that's the big territory. That's where all the action is. That feeds most of your cerebral hemispheres. 60% of strokes occur there. Vertebrobasilar artery has 15 to 20% of the strokes. Now, lacunar syndromes, lacunar strokes are strokes that occur in little teeny-weeny branches of any of the arteries, but they're probably more common in the middle cerebral circulation. They're such small branches that they're not named. They're such small branches that they can't be treated with much of anything, and they don't show up as acute strokes in most of our imaging stuff. We see these after. So these are, but they will cause minor stroke syndromes and occur more commonly in quite elderly persons. They may, it may be, it's thought by some neurologists or many neurologists that lacunar strokes are what contributes to some causes of dementia in older persons, that they've had tiny small strokes and almost not, you know, so never causing them to be paralyzed, never causing them to have any significant speech impediments, but causing them to be a little slower and a little bit more demented as we get older. So anterior cerebral artery, only 2% of strokes, and you get opposite leg weakness and opposite leg sensory loss. So legs, legs, legs. Middle cerebral artery, where we put most of our money. Hemiparesis, face and arm more than leg. So they could be slightly paralyzed or majorly paralyzed, but mostly it shows up in the face and arm, which is why we do face and arm testing. Hemisensory, face and arm more than the leg, so they get numb, complain of numbness. So numbness is an actual thing to pay attention to, face and arm more than leg. Hemianopia means that blindness in one field of vision. Gaze deviation, so there's usually a preference. They're looking one way or the other, and they can't look back to the other side. If this is the dominant hemisphere of their cerebrum, then aphasia is a major problem. It's the non-dominant hemisphere that's had the stroke, then they often have what's called hemispatial neglect, which means that they appear to be unaware that their arm is paralyzed or hemi-paralyzed. In the posterior cerebral artery, lots of things happen. You could get what's called contralateral homonymous hemianopia, which is a very complicated sounding name, but it's easier to explain that if you get an injury to the right posterior cerebral area, then you will have a left visual field defect. So your hemianopia is opposite to the site of the injury, but it's a visual field defect. So you injured the right, the left. When you test for visual fields, they don't appear to have any vision on their left, the left side of their visual fields. Now, we don't generally, in the past, we've never requested or never we've asked you to ask the patient if they're, you know, how their vision is, but we've not had you test it, although I think it would be a very good idea to start testing it. And there's simple ways of testing, which is you simply, if the patient's awake and cooperative, have them look at your nose and then just hold your hands to the side of their face, wiggle your fingers and ask them to see when, if they can see your fingers wiggle, and you move your fingers in toward the center. And if they cannot see on one side, then they have a visual field loss on that side. You can also get, if you have a severe stroke in the posterior cerebral artery, you can get total cortical blindness, which means totally bilateral blind in both. You're blind in both eyes. You're not. It's not the eyes. It's the cerebral cortex that is not. It's the optic cortex that's not getting any messages anymore, or putting out any messages. Then there's a very fascinating called the Anton syndrome, which is it's sort of profound spatial unawareness. They deny that they're blind. Now, basilar artery, you can get a number of different cranial nerve palsies, so all sorts of things involving the 5th nerve, the 7th nerve, 10th nerve, 11th and 12th nerve. So that could affect speech. Can give you facial palsy, intranuclear ophthalmoplegia, which is a visual issue, gaze palsy. It's a thing called 1.5 syndrome, where the patient can, because of the stroke, the patient can look. It's not a gaze preference, but one eye doesn't track laterally at all, and one eye tracks just to one side. Then the locked-in syndrome, which we've talked at before, and I think a couple of years ago, Dr. Basson presented a case of locked-in syndrome, which affects the basilar artery, is basically stroked, and it affects, the patient remains conscious, and they have sensation. They have facial paralysis, and they're unable to phonate. They have quadriplegia, so they're totally paralyzed. Preservation only of vertical eye movements and eyelid openings, so they are essentially a prisoner in their own body at that point. I think this has been treated occasionally successfully by TPA. Otherwise, it's literally a paralysis for the rest of your life. Happily, very infrequent. Posterior inferior cerebral artery has facial sensory loss on the same side of the body. Opposite side body sensory loss. Same side ataxia, which so the right hand, right foot would be ataxic, would be very uncontrollable. Basically, ipsilateral, same side, nystagmus associated with extreme vertigo. Hoarse voice, because it affects the nerves to the cranial nerves to the larynx. Ipsilateral Horner syndrome is a small pupil, eyelid droop, and absence of sweating on the same side of the face. So one of the themes in any posterior circulation syndrome is we have cross findings. So you have motor and sensory losses on opposite sides. You have nystagmus, ocular motor findings, extreme, usually vertigo and ataxia, and quadriparesis rather. Now, identification requires examination of eye movements in addition to the elements of the National Institute of Health stroke scale. Now, stroke scale is something that we do right now in the emergency department, and what neurologists always do in evaluating and grading the severity of the stroke. So it's an assessment tool. It provides a quantitative measure of stroke-related neurologic deficit, and it's reasonably valid for predicting the size of the lesion, and we use it then as a measure of stroke severity. And when we're going to recommend using a drug like TPA, which has some significant side effects and some significant side effects and some poor outcomes at times, we want to be able to tell the patient that actually we wouldn't use it on a very minor stroke, even if the patient had a little aphasia. If that's all they have, we would probably not recommend using a drug with significant contraindications and side effects. It's a data collection tool for planning care. It's 11-item scoring system, and I'm only bringing this up because you should be aware, because this is the first thing that the emergency physician will use to determine whether your patient who you bring in as a stroke, as a code stroke, whether this patient will be called a neuro 911, which is our term for a significant stroke, significant enough to put the patient into the TPA fast tracking system. The NIHSS elements that the physicians will look at include level of consciousness, questions related to orientation, being able to follow command, best gaze, visual field. So here we're testing eyes right off the bat, facial palsy, motor arm, motor leg, limb ataxia. This is most of us test it by doing a finger to nose test or a repetitive motion test of the hands, or heel, one heel down the shin, and being able to go up and down the leg with that show quick ataxia. Sensory, so there's any numbness any place. Language, dysarthria, and extinction and inattention. So that means that, you know, the patient is not paying attention to his paralyzed side. It's not even noticing it. I don't think we need to go through those again because it's essentially saying now. Well, actually, I take so. Let's see. Previous. Okay. I gotta get myself in here. Okay, this is the, so if you're looking at the middle of cerebral artery, this is level of consciousness questions, You can see if they have loss of visual field, arm strength, leg strength, sensory and language, and dysarthria, difficulty with speech. Then going into posterior cerebral artery, the areas that are affected are visual, sensory, arm strength in the deep branches of the posterior cerebral, and leg strength if it's in deep branches only. Vertebrobasilar artery, level of consciousness. So vertebrobasilar stroke can cause changes in level of consciousness. Gaze, this is, remember, they would affect how you would look, being unable to look to one side or having diplopia because you have a gaze defect. Ataxia, and once again, dysarthria, speech. Anterior inferior cerebral artery, only ataxia. They're extremely unsteady. They cannot walk. Superior cerebellar artery, same thing, severe ataxia. Inferior cerebellar artery, severe ataxia, also though associated with dysarthria, difficulty speaking. Now, why do we want to spend so much time thinking about posterior circulation stroke? Well, for this reason. Here's a little study from 2017 of 71,000 stroke patients, of which almost 12,000 of those were posterior circulation. Median time in the ED for the patient to come to the ED was 170 minutes versus 110 minutes for anterior circulation stroke. People get really excited when they have arm weakness or facial droop and difficulty speaking, but not so much when they're just dizzy or have problems with double vision. Only 8% of these were treated with TPA versus 16% that were in the anterior circulation. Now, the median NIHSS score was lower. It's only 2/3 as high as the median score for anterior circulation. So the symptomatology is clearly not as severe, or we just didn't look at it. Gordon needle was 13 minutes longer for posterior circulation cases too. We just didn't jump to it very quickly. Now, pre-hospital wise, study in 2015 of 750 patient transports over a 2-year period with ultimate diagnosis of stroke, 62% were correctly identified, 38% were missed. But here's the big thing. No patients who had unilateral weakness, facial weakness, or speech problems were missed. In other words, the MCA strokes, middle cerebral artery strokes, are picked up right away. Most common symptoms of those who were missed were diffuse bilateral weakness, which is also usually associated with ataxia, dizziness, vertigo, and headache. So posterior circulation signs. Of 103 strokes, another study in 2016, 103 strokes initially missed over a 1-year period out of 465. Symptoms and signs most missed were dizziness, nausea, and vomiting. However, if these are physicians, if the physician noted gaze preference, they put down patient has gaze preference, and they called that, then the odds of missing a stroke were lowered tremendously. So it was visual. All our pre-hospital screening tools involve facial droop, arm weakness, and speech difficulty. So it's looking for MCA strokes. Only the Rosier, we don't use that one, and the B-FAST include a vision. FAST is face, arm, and speech. B-FAST is balance or coordination. diplopia or monocular vision loss, and you could throw in visual field loss. So with our neurologic exam, we have gone to BFAST. Now, the rest of the state has not entirely caught up with that yet, but we're okay being ahead of the curve. So our BFAST is balance, so sudden loss of balance and coordination. If the patient says they're real dizzy or they're unsteady, don't stand them up and let them fall down. But that, remember, that may be one of the reasons why they fell down. Ask them, when you have a person who's down and hasn't been able to get up, ask them why, why they fell. Eyes, loss of vision or visual field. Think about asking about that and do a very quick, like I already mentioned, a very quick, simple visual field check. Face, abnormal unilateral weakness or drooping. Arms, one arm drifts compared to the other. Generally, hold it up with the palms down, and if one arm drifts away with the eyes closed, then that's the drift. Speech, abnormal, slurred, inappropriate rules, or unable to speak. And time. Time is the big thing here. So waking with symptoms, that equals onset time. Although we are taking a lot of patients with waking the symptoms to the cath lab. But it's important as much as possible to establish an accurate time last known well. Now, we then ask you to do if you have a positive BFAST, we ask you to do the Los Angeles Motor Scale, the LAMS score on top of it, which is facial droop, score is 0 to 1 if it's present, arm drift, 0 for absent, drifts down 1, falls rapidly or unable to hold it up is 2, grip strength, normal, weak, 1, none, 2. So remember those possibilities. So altogether we have a possibility of 5 total. Now, you notice that we don't spend any time on the legs, even though you may have weakness of the leg. But that's the LAM score. Remember, for the middle cerebral artery, the big strokes are more profoundly seen in the face and arm. Best gaze in our NIHSS scoring tests horizontal eye movements. If you notice they have partial gaze paralysis or forced deviation or total gaze paralysis, if they're only looking one way, that's important to note. Visual fields, you don't have to do any scoring. Just tell me or the ED doc that they can't see anything they don't appear to see anything on the left. They got a left visual field cut. Remember, airway has to be. Besides all the fun things looking at the stroke itself, you have to consider the potential problem with airway. If they have paralysis of airway structures, difficulty with handling secretions and vomiting. Vomiting is especially bad with hemorrhagic strokes. Coma, seizures, they may not be able to protect their airway. Cervical trauma due to a patient collapsing. If the patient has a history of fall, I want to see C-spine control. Breathing potential problems. If they have irregular, if they're comatose, they may have Cheyne-Stokes breathing or central neurogenic hyperventilation, indicating increased intracerebral intracranial pressure. If they have, they may have paralysis of muscles of respiration, particularly if they have a high spinal cord stroke. Manage breathing problems aggressively, maintain oxygen at above 94%, RSI as needed. Circulation, the potential problems may be hypertension. Of course, we don't treat hypertension except if it's extreme and you are anticipating that the patient is perhaps going to herniate at the brainstem, then controlled moderate hyperventilation might be in order as you're going to the emergency department. Treat hypotension. Hypotension and shock is bad for strokes, just like it's bad for patients post arrest and in trauma. Try to maintain your blood pressure in the 110 range at least, and treat dysrhythms as indicated. This is from your standing orders. Treat per universal patient care protocol. If CBG is low, treat per altered mental status. So you're going to grant CBG on every potential stroke. The BFAST assessment is here. Balance, eyes, face, arm, speech, and time. Note time last known normal or last known well. So if the time, note the time they awoke, and note a time of symptom onset if they know. Now, we had a recent case that I'm not going to go over in any extent today, but Dr. Gadbois reviewed this case, and the patient was semi-comatose at best, and was noted by his wife to have been that he was in bed when she went to work, and then he was found. So that was the last time she, quote, knew that he was well. Patient was brought to the ED, and upon questioning, they then contacted the wife again, and she said, well, yes, he was in bed when I left, but I talked to him later on this afternoon, about 2 hours ago, and he was perfectly well then. So that's kind of a big difference. There was a difference of about 8 or so hours. Now, interestingly enough, the patient, all this was going on while he was in the CAT scan getting evaluated. He'd had as I would have suspected, with a loss of consciousness, he had a massive intracranial hemorrhage due to hypertension, and was not able to be treated with TPA anyway. But that's still important, though, to establish your time last known well. Then we want you to do the Los Angeles Motor Scale if the patient has a positive BFAST, and that is facial droop, arm drift, grip strength. Now, if you suspect a bleed, normal ventilation rates, target ETCO2 at 35, titrate O2 to the lowest level to achieve O2 of 94 to 98, ETCO2 of 35. Reassure patient if conscious, patient may understand and hear all conversation, even though they may appear confused or comatose. Transport emergently if the patient meets any positive BFAST findings less than 24 hours, critical, profound paralysis, aphasia, comatose. Notify receiving facility of code 3 stroke. Patients will go to Peace Health Southwest, which is the interventional center, with any patient with a LAM score, so a positive BFAST and a LAM score of 4 or 5. Any patient 80 years old or more. Symptoms more than 3 hours, but less than 24 hours. We've actually taken some patients to the cath lab in just short of 24 hours. Suspected intracranial hemorrhage, they go where the neurosurgeons are. Sign of profound paralysis, aphasia, or comatose. Remember, profound paralysis, aphasia, or comatose, that's probably, I mean, that's a significant enough stroke that needs an intervention of some sort. Now, the symptoms are less than 3 hours and they do not have LAMS of 4 or 5 or any of those other things. They can go to the closest stroke center for consideration of TPA. Now, it is preferred that the patient's family members be there to get medical history. Now, unfortunately, with the COVIDs now, we are not allowing patients into the patient's family into the rooms for quite a long time. And then, but they can still, we need to either have them there or have them next to a phone so we can get more information from them if feasible. And also we're going to need permissions from the family for procedures. Now, a little side thing for COVID and stroke. New England Journal article, April 24th, so current. All stroke patients in New York City under age 50 during a 2-week period in late March, of those stroke patients, 5 patients aged 33 to 49 had large vessel occlusive strokes before they actually had severe symptoms of COVID-19. So they were coming down with they were developing the symptoms of COVID-19, but developed LVO strokes. This is 7 times the average for this age group. So that was particularly, now this is a case report, it's not a study, but it's just an interesting thing to look. So we also noted that there have been reports in COVID-19 patients of increased intravascular clotting. In China, 71% of the deaths in a study of 183 persons who died, 71% of the deaths at post were found to have abnormal clotting, where 1% of those dead did not have any evidence of clotting at all. Now, this is possibly due to ACE2 receptors, which are common in respiratory tissues and vascular wall, and the ACE2 receptor is also implicated in how the COVID gets into respiratory tissues and also into the vascular wall. So it's likely that there is some significant increase in strokes. Now, some quick stroke data. Legacy sent us some volume comparison. They had an increase in 2019 of about 26 strokes. Most strokes arriving at Legacy come in by private vehicle. So they are presenting at the emergency department door, and then are sorted out from there. They have about the same amount of EMS transport. Their acute ischemic stroke level is about, and TIAs, which are, of course, premonitory for stroke, are the vast majority of their stroke types. Their door to needle time when they do treat patients for with TPA is good, being about 45, 50 minutes, and door to needle time, interesting, when you arrive by EMS is a little longer than by private vehicle, which I have no good way of explaining that. For Peace House Southwest, I thought you'd be interested in seeing the percent of code 3 strokes that were upgraded to Neuro 911. And you can see there's essentially, except for July of 19, there's a steady uphill climb from a low of about 48%. So less than half of this stroke, of your code 3 strokes were upgraded to Neuro 911s, but now we're at 66% in March of this year. So, and this is a fairly steady curve, showing that either our ability to diagnose and to anticipate a stroke is improving, and so the ER doc is agreeing with us more. So we're well above, and I'm more than happy to have a 30 to 40% overcall, because one of the reasons that we make a code 3 stroke a Neuro 911 is that the patient fits the window of being able to be treated. They have no confounding factors. They have no problem with their clotting factors. They have no problem with their blood count, etc. They're not hypertensive. So there's a lot of reasons to not, even if the patient has a stroke, there's a lot of reasons to not get TPA. And to be a Neuro 911. Just like if you have a very low NIHSS score, then you would probably not opt for TPA treatment either. This shows the code 3s coming to Peace Health, and you can see that it's a low code 3 strokes. It's a low number. It's a low month that has slightly more than 30. The high months have 65 coming by ambulance. Door to needle time, this looks like a bad EKG tracing, but you can see some of the door to needle times have been as quick as 30 minutes. The average, the gray line in the center, this is a 40-minute time, and a lot of these patients are getting at 40 minutes, and this is the median, which we like to get at 60 minutes, right across there. And there's a few outliers here that when the patient is not clear. Now, sometimes the stroke symptoms come and go in the department, and this becomes sort of a hesitating, sort of a stuttering stroke. Takeaways from this, then, I think our stroke care is improving. We are asking the hospitals to report, more importantly, missed strokes. So if a patient comes in by EMS and they ultimately turn out and they don't come in as a code 3 stroke or a suspicion of a stroke, and then the patient ultimately turns out to have a stroke diagnosed, we want to know those, because we want to improve our pre-hospital diagnostic ability and our anxiety, if you will. Like I say, I'm more than happy to have a 40% overcall because then we aren't missing strokes. This is a very tight time window to treat patients easily. We are also reviewing and trying to tighten up the information we get from WMSIS on our stroke thing. Be careful to list both the BFAST and the LAM score in your charting. Be sure to list your blood glucose and all your pertinent findings, and list that you have made this a code 3 stroke. It's easier for, it's easy for us to pick this out of the mandatory fields than it is, electronically, than it is to have to go back and go through all of the narrative. All right, I think we are done. I guess I went a wee bit over. I got, by my watch, I'm at 70 minutes, which is probably a record for me anyway. In the next couple of weeks, we will be having case reviews. Once again, Dr. Gadbois will be the presenter. Let us know. I don't know, Mark, do we have ability? I don't see a chat thing on this now. Maybe I do. Let's see. But maybe have some questions. We can
There's no questions in there.
Okay, good. All right. Well then, you can send questions to me as you want. I'll try to answer them. If I was confusing at all at any point, I apologize for that. Have it, stay safe, keep washing your hands, and I'm very proud of how everyone has been managing the PPE, and we have had no EMS persons that we can who have turned positive to COVID-19 that we can attribute to an exposure to a patient. So thank you very much. Enjoy the rest of the day and the week.